Hello and welcome to this Clinical Care Options podcast. I'm Nicola Hansen, Scientific Director, here with Dr. Alireza Atri, Chief Medical Officer of Banner Research and Director of the Banner Sun Health Research Institute, and Robin Martinez, a patient advocate who manages the online communities and patient engagement at Smart Patient Thing. This episode of Cognitive Conversations will discuss HCP patient communication regarding brain health and cognitive decline, with a focus on general neurology settings. This podcast is part of our 2025 Brain Health Program in partnership with Practicing Clinicians Exchange, Smart Patients, and the Society for Post-Acute and Long-Term Care Medicine, and supported by an educational grant from Lilly. Please visit the show notes for a link to our Brain Health Resource Hub containing many additional activities. Now let's get started and hear what our expert has to say.
Hi, Ali. It's a great pleasure to have you here today. I'm really excited about this session because I understand that the Alzheimer's Association has new clinical practice guidelines so that healthcare specialties across the board, including primary care, can know what they need to do for routine cognitive evaluation for brain health and memory impairment and so on. And you were highly involved in developing those guidelines. So first of all, thank you for that. Second, can you start by telling us about the goals and how these guidelines will be used?
Yeah, thanks, Robin. It's a pleasure to be with you today. The guidelines were the combination of a 7-year Institute of Medicine guideline development process that involved basically multiple stakeholders, including primary care clinicians, neuropsychologists, psychiatrists, geriatricians, cognitive neurologists, etc. And this was the first attempt for the Alzheimer's Association to provide a guide, evidence-informed and evidence-based guideline for a comprehensive evaluation in any setting. So whether it's primary care, specialty care as in neurology, psychiatry, or subspecialty care for, Alzheimer's and cognitive and dementia specialists. So that really was the goal to set that up, and knowing that our paradigm is really shifting, both in how we approach diagnostics and then evaluation and with biomarkers. And this was the first sort of attempt to use this process to develop something that's practical for clinicians. And as new treatments and pathways emerge, they can use, this approach to look at diagnostic criteria for what the patient has. This is not giving people diagnostic criteria. This is just basically putting in the evaluation process into recommendations that are broken down into steps.
So does it start with the very basic problems like, I don't think I'm remembering things as well as I used to, all the way up?
Yes, the who. So it starts with the who and the how and the what. The who really is a person that comes to you. In this case, actually not somebody without symptoms. So this is really focused on people who may have a concern or a symptom, or you may have a concern about something that's going on with them, or, an informant, somebody who's with them has a concern. So that's really the who. And then it actually goes through about what elements of the history, how do you actually, come together with that person in a person-centered way to come up with the goals of the evaluation, what elements of the history are pertinent, what are the risk factors to think about, including a lot of brain health risk factors that are important to assess, and then going through what we call a 3-step diagnostic formulation. Which ultimately brings you to deciding whether this person is cognitively unimpaired. Are they normal? Is this a subjective cognitive change, or there's something more at the level of objectively the condition of mild cognitive impairment or dementia, for example? And then if that's the case, that's the first step. Then the second step is to figure out whether what is the pattern of the symptoms. And the third step is what is the etiology, the causative factors and the contributing factors to that. And then we use, testing and biomarkers, including imaging, and we sort of have recommendations for all those, everything from what standardized tests should be potentially included in the evaluation in the primary care setting or the neurology setting or a subspecialty setting. How do you use MRI? When to refer a patient, for example? What about neuropsychological evaluation, spinal fluid, glucose PET, amyloid PET, genetics? So all those have a recommendation, and then they also have flows. But at each step, what's really, really important, whether you decide something's wrong or not, always to actually think about bringing up healthy brain, sort of preserving behaviors, and always counseling people about that. Because even though this is a sort of a evaluation and disclosure guideline, the one thing we can always do is think about brain health.
So, yes, definitely. And brain health should be considered really in every appointment, I think, with every doctor, but often it isn't. So, for example, how and when does a doctor decide this person needs to have their meds looked at, or this person needs to have their vitamin levels checked to make sure there's not a vitamin deficiency? And how can we keep that from falling through the cracks? Because those are some very basic problems.
Perfect. So these guidelines, right? So they actually give you a step-by-step. They give you, there's 19 recommendations. They say, if you go through it in this formalized way, and these are the tools available to you, right, at each step, you should be able to go through this diagnostic pathway to decide when to use what we call tier 1 labs, for example. That's the cognitive lab panel, which includes comprehensive metabolic panel, a CBC, a thyroid check, vitamin B12, homocysteine, a SED rate, ESR, a CRP, for example, is in there. And why do we choose those? Those are things that are relatively actually, it's a broad net, and it's based on both availability and cost. And it catches things that are not necessarily very uncommon in people who are older, and that can tip off cognitive changes, for example. And then it tells you what other lab tests and studies and how to tier them so that you're not shotgunning and getting everything and everybody. But at some level, when your concern is high enough, or you think that they're in this pathway at a particular level, then you should actually be sending those studies in. And the tier 1 involve these lab tests and actually a brain MRI without contrast. Yep. And those are what we call level A obligations. So highest level, meaning that if you do that, you actually are going to improve patient care for most people. And these guidelines were internally reviewed, externally reviewed. They were sent to some societies. Feedback was received from them. And so an MRI is something that really is considered tier 1 for somebody that goes down the pathway a certain amount.
So one good thing about this that I'm hearing is that a lot of these things in tier 1 are something that can actually be dealt with medically and possibly changed, like improved nutrition or getting better sleep hygiene, checking for sleep apnea, all these things that.
Yep, absolutely. Those are all on as part of the risk factors and part of the structured interview that one should consider. Because even though, for example, at some point, there may be a condition and someone have mild cognitive impairment and they want to go to the pathway and figuring out exactly what's causing it. So going down the pathway of biomarkers, for example, for amyloid or tau, et cetera, but whether it's spinal fluid or an amyloid PET scan, guess what? You got sleep apnea and you have Alzheimer's changes in the brain. You can do something about both of those things, right? And so, we're not absolutely great to know what are the drivers of cognitive impairment, because most people have multiple things that are causing and or contributing once they get into their, mostly in their 60s, 70s, or 80s, and they have cognitive changes. So this is, you mentioned meds, for example, inappropriate meds. So we look at Beers criteria, looking at anticholinergic load, for example, looking at over-the-counter medications, for example, people taking medicines for sleep, not knowing that it's got the PM label on it, which oftentimes means it's got diphenhydramine, for example, that could be very cognitively suppressing. So all those things, alcohol intake, use of drugs, interactions, stress, levels of sleep, other sleep disorders, they're all there.
And UTIs. Urinary tract infections are something that can cause such a sudden mental status change in older people, and most of us don't realize that.
Correct. Because it could be subclinical. People could have, it's sort of the canary in the coal mine. The brain, when it's a bit vulnerable, right, can actually show its symptoms first. So like you said, you may have COVID brewing. You may have a subclinical UTI where you might not realize that you actually have burning down there, or you have a little bit more urgency. But that inflammation actually, in somebody who's vulnerable, can make them confused at the time. And actually, that's one of the reasons we have this pathway of saying, you should tier the evaluation a certain way. And the ESR and the CRP from the blood is actually part of to catch some of those inflammatory and infectious conditions.
Is there any way for people or for doctors to make sure that an older person's living conditions are appropriate? For example, having enough lighting. In the afternoon and evening, as it gets darker, a lot of people get upset and disoriented, and just changing the level of lighting may be enough to help them through that period, or making sure that there aren't fall risks like throw rugs that no longer serve any purpose, but they're there as a trip hazard. How do doctors approach this?
Well, I think every setting's a little bit different. And so part of this is getting the word out, both for patients and their care partners to be aware, and for clinicians. I think many folks who are in primary care and geriatrics who focus on this, are pretty good at asking about those things. But I think getting the word out to it more broadly is important. So some of those things that you mentioned, sort of there's a bio part of it, but then there's the psychosocial environmental part. And so not to forget the psychosocial environmental part about what's going on. And so we, in the practice guidelines, we have boxes about delirium, just what you mentioned, encephalopathy. We have boxes about, healthy brain behaviors, we call them. We have boxes on assessing balance and motor function, because assessing a mood and neuropsychiatric symptoms, and, having sort of, catch-all terms. And also we have scripts about how to bring this up, because sometimes people don't know how to bring it up and how to disclose and talk about it, which is important. Ultimately it's hard to do everything in one visit. So we even talk about breaking it up. But the very first step really is to have a patient-centered discussion to align with the person, and oftentimes involving someone who knows them well, right? To get collateral information, and then to break this up in multiple visits. And part of that, again, is to figuring out what's important to that person. And for most people, it's not like they want to spell world backwards. Nobody comes in and says, gosh, I want to get, half a point more on my MMSE or in the CDR. People want to retain their personhood. They want to have quality of life. They want to retain independence for longer. And so in those ways, we want to be proactive to talk to them about these opportunities. But gosh, in the same way that we would check your blood pressure, we need to check certain things about your balance, motor function, your environment, your health, your nutrition, your sleep, your alcohol intake, all these other things, right? And as part of it, you want to establish a base. So that's why, for example, the annual Medicare wellness visit is such a good place to do that. But it may require multiple visits.
So how do you get people back for multiple visits without frightening them?
Well, it's establishing that alliance with them and aligning about the importance of this, to see if, for them to appreciate, first, what is important to them. And oftentimes those things are important. People don't want to lose their brain. They don't want to lose their independence. And then, explain to them that this is the pathway to do it is to actually establish those baselines. And once you do, then you could figure out what sort of things may benefit them. It could be a visit to physical therapy for assessment and balance and gait, right? It may be a nutrition consult, but you can't get those unless you sort of, you start talking about them and going through a systematic approach of assessing them.
And so many people have physical comorbidities. They say there's never time to talk about these things with their doctor, even if they want to bring them. So yes, bringing people back, bringing them into the system and realizing that these are important concerns for everybody is so crucial. So when do doctors recommend testing for biomarkers for specific types of dementia? Are there specific keys or points at which that happens?
Yeah. So I think what is pretty clear in the guidelines, and I think for appropriate use, is that the person matters, right? You don't have a biomarker in isolation. Context matters. It has to be person-centered. So it's not like, oh, I've come to see you and you're like, well, I'm 60 years old, maybe I'm slowing down. Maybe I had a family history of Alzheimer's. And the response is, oh, let me check this blood biomarker. By the way, as of Friday, we had one FDA cleared for the first time. And even that is pretty clear. That's not used on people with that kind of impairment and shouldn't be done outside of an assessment, right? So nobody should be abstracted to one dimension, one number, whether it's your MoCA test score, whether it's your biomarker level, any of those. It has to be really wrapped around in a context of an ongoing evaluation. So at what point these should be ordered, this is part of the CPG, the clinical practice guidelines, that says, you know what, you should go down this pathway. And if you get here and you're not sure about X, Y, and Z, you can refer. Or these are the tests available to you that you could do. But, again, the tests that are like amyloid PET scans and spinal fluid, those still are things that require interpretation and context. And at this point, that's still, I think, in the domain of the specialist, as opposed to most primary care who may not have this as their interest. Ultimately, as the blood biomarkers become better and more accessible, then in conjunction with an evaluation like this in primary care, then that can actually give a lot of information about what should be the next steps. But if the person getting the test really matters, if you give it to somebody young who your probability of having these changes is low, and you give it to many people like that, then the likelihood that a false positive occurs is really high. And so context really matters. And that's we could talk about that in a different way, but there's, you could use Bayes' theorem and but basically you have a prior probability that we all of us in our head decide. And then those are the people who give the test, because your positive, negative predictive values really, even if the sensitivity and specificity of this test are a certain amount, they really matter who you're giving it to, right?
Whether the answer is a likely answer or not.
Or not. Yes. I'll give you an example. Let's say I'm 75. I go in and I have certain complaints that are very consistent with me potentially going to, late MCI, mild dementia stages. And my PCP does the workup, right? Actually gives me a couple of tests, asks me the history and says, gosh, in my head, I'm thinking probably 85% chance that you have Alzheimer's, right? You take that 85% number and you take a test that 90% sensitive and 90% sensitive and 90% specific. And the result comes back in that situation as negative. Let's say negative. Guess what? There's almost a 40% chance, if you do the math, that's a false negative. So, right?
So you have to look at the clinical signs.
Exactly.
As well as
it still matters. And guess what? How do you form your clinical opinion? By talking to somebody, by understanding how they've changed, by actually testing them, giving them standardized tests.
I wish everybody had this available to them.
Yes, part of the CPG was to actually say that this is standard care, to show an evidence base so that these are covered, these things would be covered. And fortunately, over time, with these new therapies that we have, and with evidence like this amassing and, having this high level of evidence, it prompts healthcare systems to provide these opportunities for clinicians to do this work and insurers to actually cover that.
Well, thank you so much for being here. This has been a wonderful and really challenging discussion with a lot to think about. So it's been great to have you. Thanks.
Thank you, Robin. It's been a pleasure. Be well.
Thank you very much, Ollie and Robin. And thanks to you, the listeners, for joining us. Please look for 4 other companion podcast episodes discussing cognitive conversations in other clinical settings. As a reminder, to visit our full brain health resource hub, please click on the link in the show notes. As always, thanks for listening.